Welcome everybody to the latest Global Nursing Network for Rare Disease Education webinar. Thank you to everyone that is joining us live today, and hello and welcome to all of our viewers on our YouTube channel. My name is Sian Gannon. I am the Clinical Nurse Specialist for the Rare Care Centre in Perth, Western Australia. I'm a member of the Global Nursing Network for Rare Disease, and I am your host for today's webinar. So for all of us who are joining us live, please note that today's session is going to be recorded and will also be then put up onto our YouTube channel for later views. As a global network, I just want to take a moment to welcome and pay my respects to everyone around the world. As a global network, we respectfully acknowledge the Native, Indigenous and First Nations people on whose ancestral land we gather around the world, as well as the diverse and vibrant cultures that they represent. So just a little bit of admin before we crack on with today's amazing speaker. Please ensure that your microphones are on mute whilst the presentation is being given. We do encourage you to have your video on just so that we can put a face to a name to build this community of practice that we are working hard to create. Please feel free to utilize the chat function throughout the session. You can pop your thoughts, questions, and please put in where you're from in the world as well. We will be looping back around to ask questions that have been put in the chat. At the end of the presentation, there will be an option and an opportunity to ask any questions that you have of our speaker. And we do encourage questions. No question is a silly question, and all of your thoughts and questions are welcomed. So I just want to take a moment to thank you for your attention, and I am quickly going to pass on over to our speaker for today, who is Tessa. Tessa has been a nurse for over 20 years. For 14 of those years, she has been a paediatric nurse practitioner involved in caring for children with medical complexity and rare diseases in Canada. She is currently the clinical planning lead for the capital project for the BC Children's Hospital in Vancouver, Canada. The project is building a new centre and new clinical program for children and youth with health complexity. Tessa will share about the new model of care, the new centre, and the clinical planning process. Tessa, I'd like to hand over to you.
Thank you for the introduction, and thank you for the invite. I'm excited to share with you about the new BC Children's Hospital Centre for Health Complexity in Vancouver, British Columbia, Canada. Start by acknowledging that I'm on the unceded, which means stolen, ancestral and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. And our clinical planning team and our project team for this capital project that I'm going to tell you about are really mindful of the colonial history of healthcare that has taken place on this site in East Vancouver that we're redeveloping, and aim through engagement and culturally safe practice to improve healthcare going forward for Indigenous people in British Columbia and Canada. So the purpose of this presentation is to just go over the project overview, tell you a bit about the population that we're designing for, tell you a little bit about how we do our planning and the new model of care at the new center, and then I do have a bit about building design at the end if we have time. So this is a really exciting project. It's a capital project through BC Children's Hospital and Provincial Health Services Authority. This is publicly funded healthcare in Canada, and this new service is within BC Children's Hospital. It will be a program within BC Children's, which is the single pediatric acute care hospital for all of British Columbia and Yukon. So an enormous geographic area where many families have to travel very long distances to come to Vancouver to receive pediatric acute care here. So this new center will again be located in Vancouver with a real focus around virtual care delivery so that Families who can receive services at this new center can do so either in person if they are in Vancouver or virtually if they're not. This is a purpose-built facility, so it's really exciting to be designing a project with and for families of children with health complexity. The new service will open, the new building and the new model of care and service will open in early 2028. And what's exciting about this is typically in redevelopment projects, capital projects, a new building is built and existing services move from one location to another, or they might be expanded upon or changed a little bit. But this is unique in that this is a completely new clinical program that will go into the new building. So net new staffing and clinical planning. And the new service will really address very well-known gaps in care for this population across BC and Yukon. So this is the project timeline. It just shows the design build project timeline kind of high level for the actual building itself, which opens in early 2028. We're at this stage now, which is construction start in early 2025. And our clinical planning process, designing the new clinical program, mirrors this timeline so that we have a new center, a new program to start in the new center when it opens. But we will have some early implementation opportunities that we're looking at over the next few years to test out this new model of care before officially opening in 2028.
So this slide just shows like a really high level snapshot of how we do our work, which is through engagement. And we're refining how we collect this data. And I have to admit, I'm like so inspired by the Rare Care Center in Perth around how you capture the data and show what you're doing. So we have some work to do on this, but suffice to say that we have a lot of active partners in our clinical planning. And this is just clinical planning separate from the actual design of the building, which also has a huge number of partners. So really, we're working closely with our Indigenous health colleagues, which is the picture on the top left. We have a patient caregiver advisory group and an extremely engaged group of families that have been with us actually through business plan phase. So many of them have been part of this project for several years at this point. We do have families coming and going from that advisory committee, and some are more involved in some areas than others. It's all sort of their choice. This picture in the middle here is a picture we have permission to use. This is Nolan, who is a child with health complexity, and his mom Darlene, and they're walking through a mock-up of the space where we had, basically cardboard walls, and but we were mocking up the way that the child and family suite will look in the new building, and physically moving through the space and like testing it out. And this is Darlene having like a talking to with our lead architect. So really like embedded in the planning as partners. And then we have, a huge number of clinicians who are part of our planning team. And some of them are involved on, like a weekly to monthly basis. And then others kind of come and go for various workshops, depending on their subject matter expertise. And because we're designing a service that is intended to support families across sectors, we have partnerships across sectors and in community to make sure that those services and supports are represented as well. So this is just some highlights. This certainly doesn't capture everything, but we've done a lot of engagement over the last couple of years as we've really added layers onto the business plan, which was approved by the Ministry of Health in 2022. So that business plan was pretty high level. It had a lot of good content, and it really it set our direction, but it really had very little in the way of fine detail. So our job over the last couple of years has been through engagement to really layer on to that business plan. So we worked with a human-centered design firm, which was a really positive experience. They did a ton of engagement on their own with both families and healthcare providers. And we learned a lot about the human-centered design approach and continue to carry that through our planning. Like I mentioned, we have a patient caregiver advisory group that at any given time has 13 to 16 people. we've had 17 workshops to go through each component of the new service model design, and really flesh out in an iterative way exactly how to design the future program. We've done a lot in terms of environmental scan and information sharing. And then, as I mentioned, we've done things like the mock-ups. We also have a VR mock-up coming up soon. So families and staff will be putting on VR goggles and walking through the space to provide feedback in that way in the coming weeks. I mentioned partnerships with our Indigenous colleagues and families. So we have a BC Children's Hospital Indigenous Health Program that is quite robust and expanding. We partner really closely with them to design the actual clinical services to make sure that we're planning for culturally safe care, as well as traditional practices being embedded in the service delivery. But we also have designed Indigenous focused spaces within the building. So that includes a healing garden, a gathering space that's kind of depicted here. We also have an elders room and an all nations space. So there's those specific areas of the building that they've been in partnership with us as well. And then we're working with our local nations around land recognition and translation of indoor and outdoor signage, as well as art on the site. All right, so now I'm going to jump into who this new service and site is for. So we're referring to this population as children and youth living with health complexity. And we know that many of these children and youth have rare disease. So I'll sort of zoom out and then speak a little bit more to that. So really, how do we define this population? It's a similar definition to those of you who are in the world of caring for children with medical complexity. In the literature, the definition is very similar. So these are children and youth who have complex multi-system chronic health conditions. They have functional limitations such that they require support around the clock. They need a lot of support with their activities of daily living, and many of them require technology to be able to survive and manage their daily living activities. They have substantial healthcare needs to the extent that their caregivers really need specialized training and knowledge to be able to look after them. So that creates a situation where caregivers can't depend on a babysitter or another adult to sort of just step in and take over care without training. So really the children need caregivers who have that added level of knowledge and skill, and many of the caregivers have an incredible amount of knowledge and skill that to the point that they're running, really small hospital environments within their homes. And then, of course, these children and youth use an enormous amount of healthcare resources. There's lots of estimates that although less than 1% of the population, they account for up to a third of pediatric healthcare spending. And that number has kind of, been looked at in both the US and in Canada. And that doesn't account for the cross-sector services and supports that they use. So yes, a lot of services and supports within health. They're followed by multiple subspecialists. They often spend lots of time in hospital. They have prolonged healthcare stays. They're interacting with the health system on a regular basis, but they're also requiring lots of support through what in Canada would be the Ministry of Education, so school supports, Ministry of Children and Family Development, which provide funding and equipment, respite and in-home nursing supports. So really touching on a lot of other sectors across the system. And then when we think about the number of children and youth that fall within this population, we talk about a target population of approximately 2,000 to 2,500 that this new center will be designed for. And as you can imagine, operationalizing this definition is a bit tricky. So we all know who those most medically complex children are, that I sort of imagine at like the center of this group of 2,500. And then as you move further out to the edges, it becomes trickier to really operationalize this definition and define. And so that's the work that we're doing right now to really get into the weeds around looking at the children and youth that are currently followed at BC Children's Hospital in our acute care center and figuring out which of those from which clinics. It's really a smattering across all of the subspecialty clinics who are followed, who will then meet criteria for this new program. And right now in our system, we only have one program that groups these kids together, and that is our acute care hospital complex care program. And they only follow about 80 children. So this is a huge expansion of that service. So this will be the first time that this larger group of children with health complexity is grouped together in this kind of way. And then we also recognize that although most of the 2,500 are going to have been seen at BC Children's Hospital and likely followed actively by multiple subspecialty teams, there are some families who, for a variety of reasons, are not seen there. They've either fallen through the cracks, or they are not getting the service that they actually need, or they live in rural and remote communities where access to care is difficult, or they're facing other barriers to social determinants of health. So then we've thought kind of carefully about how would we go from a community-based perspective to make sure that those children and families are brought into the program where maybe they should be followed at BC Children's, but for whatever reason, they're not accessing that care. So within this population, we know that a large portion of the children and youth with health complexity are born with their health condition. So they're either born prematurely, or they have a genetic condition and or rare disease. And so this is a group that makes up a big portion of this group of children living with health complexity. And we think that the service that we're designing is going to really be flexible enough to address the needs of children with health complexity, as well as those with the unique experience of having a rare disease. Part of that process being, that diagnostic journey of getting a diagnosis of rare disease, and then the treatment pathways often being slightly different or more complex. But we're hoping that the model that we're designing is inclusive of that population, and sort of trying to embed the knowledge needed to be sure that that population is receiving the care that they need. So I'm going to speak to the new service model planning. So I'll get into a bit of the nitty-gritty about what it is that we're actually going to do in this new center. So really, it's straightforward. There's 3 key services, and those are care coordination, teaching and training, and family wellness and support. And I'm going to get into each of these separately. But first, it's important to note that these 3 core services do not duplicate care existing in our system now. So these services are designed to address really well-known gaps in our landscape of care in BC and in Canada. There have been many reports, national reports, local reports, reports authored by families, reports authored by a whistleblower in our system called the Representative for Children and Youth. All of these reports have really clearly pointed toward the well-known gaps in care for this population. And so these new services are really designed to address those gaps. Acute care will remain at BC Children's Hospital and in the variety of community hospitals across the province and territory. Pediatric rehab care will stay at Sunny Hill, which is our pediatric rehab hospital. And Canuck Place is our pediatric palliative care service and site, which provides end-of-life and palliative care expertise across the province and territory. So those will remain, and these will be add-on or new services. So I mentioned virtual care being really important. So we have a variety of ways that care can be delivered at this new center. Obviously, in person is possible, so anyone is welcome to come on site to receive the services and supports. But there's been really purposeful and thoughtful planning around virtual care, because we know that, for one, it's really hard for this population to travel. it's expensive. They have to take time off work. Their children and youth often have a hard time traveling. They have a lot of equipment. It's very hard on them. Logistically, it's challenging. So there's a lot of good reasons why virtual care is needed. And the pandemic really showed us the strength of being able to provide virtual care. But importantly, we're not just planning services to be able to be provided virtually, but we're also designing the building so that there can be a good experience for both the provider and the person receiving the virtual care. So thinking about the way that spaces are designed, the technology that we're using, so that we can really enhance that experience and have it not be like, I don't know about everyone else, but through COVID, we would often, it was like all of a sudden overnight we were providing virtual care, and it was with poor lighting and terrible backgrounds and lots of interruptions and poor audio and all of these things that really impact the ability for the healthcare provider to provide good care, but also the experience on the other end. So just trying to be thoughtful about that. We've had some really great conversations with families about how to make this better. Okay, so I'm going to dive into each of the 3 core services, and I'll spend most of the time on care coordination and then move on to the others. So care coordination is really the foundational service at the new center. Really, this is a longitudinal service where families and children will be partnered with a navigator or navigator triad, so a group, an interprofessional group of healthcare professionals who get to know their child and family well over the long term. The point of the longitudinal care is really around relational care, trust building, and recognition that care for this population ebbs and flows over time. So we know that through periods of transition, at time of diagnosis, when school is starting, post-hospitalization, there's all these periods of time where we know that the need for care coordination ramps up. But then there's other times where sometimes things are going smoothly. And so a child or family might be more quiet on a navigator's caseload. And so really the navigator triad, the group of navigators paired with the child and family, are following longitudinally. And this service is really intended to be focused on the goals, needs, priorities of the child and family, and really addressing gaps and needs around care coordination. So there won't be a replacement of, say, subspecialty care. So the nurse navigator will not replace the neurology nurse, but instead addressing gaps in access to care and care coordination. I'm going to tell you a little bit more about the staff involved, but a couple other things about the model in general. One is that we've heard really clearly that given the huge geographic area that this new service will cover, it's really important to have a regional approach. So what works in Terrace, which is in sort of mid to northern BC, is very different than what would work if you lived close to Vancouver or on Vancouver Island. Each community, each region has a very different network of services and supports. They have a different degree of confidence in caring for this population. A lot of it depends on if there's a pediatrician in the area and if that pediatrician is confident caring for this population. So there's a lot of variation. In that comes inequity. So you can imagine that depending on where you live, your access to care is really different. And the majority of services and supports for this population exist in and around Vancouver. And so that creates a real challenge for families outside of that area. So the idea is that families will be connected to a navigator grouping or navigator triad that follows children who are all in one geographic region. And we're exploring different ways where one member of that triad of navigators can actually live and work in community. And so we anticipate this will probably not be one size fits all. Like we might have one model in one area of the province and a slightly different model in another area of the province, but being able to flex and be individualized in that approach is really important, because we know that getting to know the services and supports and the people and developing relationship and trust over time with that circle of care in one region is critical to the success of care coordination. And having been a healthcare provider who has done this for the whole province, for kids across the whole province, it's virtually impossible to get to know all of the services and supports across such a huge area. The other thing from big picture perspective is that there will be an after-hours support line. We've heard this being as a really important piece of care coordination. So after hours, weekends, and evenings and overnights, there will be a service where a family or a care provider in community can call for not medical emergency 911 type of calls, but for urgent time-sensitive issues. For example, a medical technology issue like a tube blockage or managing through a pain management care plan. So that type of support will be available after hours. So this is the current staffing model, although even in the time since I put this presentation together, we're like shifting it all the time based on feedback. So it's not quite right. So this is that navigator triad that I was talking about. So each of these one of these navigator triads will be connected to about 150 children and youth in one particular geographic area of the province or territory. The nurse navigator and social work navigator, I think, are probably self-explanatory in terms of scope and role. The idea here is that there's a need for both, and there's opportunity for coverage and backing each other up with acknowledgement that there's significant role overlap. This logistics navigator is a new role in our system that we're creating a new job description and qualifications for. And the idea is that this is sort of a super clerk within our system, somebody who can do coordinated booking, but who can also support logistics around travel and paperwork and pieces of the puzzle like that. So in some programs, they have family navigators or they have family partners. And so this might be something like that. And then to support this navigator triad, we have, it appears as one person here now, but there's going to be 3 of them. So for each, there's going to be 3 of these navigator triads paired with 1 medical staff, nurse practitioner or physician, 1 dietitian, and 1 pharmacist. And that's to really acknowledge contextually the big gaps in care in BC and Yukon. There's a huge challenge around access to dietitian and pharmacy supports, as well as a huge burden when it comes to those needs, feeding and nutrition needs, and polypharmacy amongst this population. And then supporting in a consultative way is an interprofessional team that focuses really around training, education, and support. And that will include people like a behavior analyst, an occupational therapist, and a teacher. And we also have a family wellness and support team, which includes paid peer support and a counseling team. We also have an Indigenous health team that we're working with that team around how exactly they'll be embedded within this model. So the training and education service is the second of the 3 core services, and this is really intended to increase the confidence and competence of the big care team of people that look after children and youth in community. So obviously, parents and caregivers are one of the main audiences for training and education, but also people in community that are healthcare providers like pediatricians or nurses or dietitians or OTs, as well as unregulated care providers and supportive people. So it might be a grandparent or a neighbor or a group home provider or a respite provider that needs training and education. And the whole piece here is around increasing capacity and knowledge so that families can spend more time closer to home if that's in alignment with their goals, rather than having to travel for support. Right now in our system, there's a huge burden and responsibility placed on families to be the educators. So once they are discharged from a hospital environment and they've sort of ticked all the boxes and they have received the training that is needed to get them home safely, their child is no longer acutely unwell, they get into community and they are it. So sometimes it's 1 or 2 people who have all of the knowledge to care for their child. And should that person get sick or have to have surgery or take a break, then it's really impossible. There's nobody left. And families have told us that the stress of not only being a parent and a caregiver and then an expert on their child, and then being tasked with having to train another caregiver and put trust in that person based on their training feels really uncomfortable. So this is an effort to alleviate some of that stress. There will be a range of content offered, everything, so more clinical topics like GJ feeds and technology, but then there will also be more functional topics like accessing recreational opportunities in your community, managing through living with complexity, parenting or siblings when you have a child with health complexity. So sort of a broad range of topics that families have told us and healthcare providers have told us are needed. We have a huge list, but we've kind of narrowed it down to like our top 10 to focus on at the beginning in preparation for opening. And then we're really thinking about a broad range of approaches. So everything from some content being web-based online sort of webinar type offerings through to that you don't have to sign up for, you can just attend whenever, and then through to like drop-in online groups, drop-in sessions where you actually sign up in advance and you attend a series, through to individualized training and education that would be addressing the needs of like one unique child. The third service is family wellness and support. So this is a really exciting opportunity for us to increase access to mental health, emotional well-being, and social connection supports for the caregivers and siblings of children and youth with health complexity. We know this is a really big gap and a challenge that is in our system, and families face issues like grief and loss, isolation, anxiety, financial stress, a lot of medical trauma, and so on. And there's very little in the way of support available in Canada. There is some counseling supports if you're lucky enough to have benefits that cover it. Otherwise, it's a huge out-of-pocket cost. But families tell us that even when they do find someone, they're lucky enough to find a counselor or someone supportive, often that person doesn't understand their journey. So there's this mismatch or gap and in really understanding the experience, and likewise for siblings. So this is really a sort of purpose-built and designed service for the experiences of caring for a child with health complexity. So the staff within this service would be an interprofessional team of counseling staff. So psychology, social work, clinical counselors, maybe nurses, depending on their training, as well as paid peer support staff. And we haven't quite landed on the name, but like a peer parent advisory committee or work group. So sort of the range of supports to both ensure that the content that's being delivered to families is vetted by families with lived experience, but also that there's that ability for emotional support and connection needs on a peer-to-peer basis. And then similar to training and education, of course, in person is available, and for those that are close to the center, but we anticipate a lot of virtual and online offerings. So the last space that I'll talk about is the space in the building called Child and Family Suites, where we deliver those same core services. So this is a space where you can come to receive in-person, more intensive care coordination, training and education, family wellness and support. The Child and Family Suites will be for non-acute care. So this is for stable patients who are, from an acute care hospital perspective, ready to go home, but for a whole host of reasons might not be ready to go home. These will be short, planned, non-acute stays. So the obvious transition I've just alluded to, which is hospital to home, we know that there will be a big need for that. But we also know that there's a need from home into an increased level of care, but not an acute care center. And right now, there's no option for that in our system. Really, if you need a step up of care, you're coming into a hospital. And so this provides an opportunity for, say there's a need for symptom management, observation, or symptom management stay. There's an ability to bring a child and family in from community into the center to have an increased, more intensive experience with the healthcare team, to be able to have eyes on and strategize and work together to manage symptoms. The suites themselves, there will be 16 of them, so there's not very many. It's a very unique and special space that we need to be really thoughtful about how we use it. So we're thinking really carefully about which children and youth would actually come and stay on site. And we know that in some cases it will be the most medically complex children who have maybe a prolonged hospitalization where their baseline has changed significantly, and there's a real need for intensive training, education, confidence building, and support. But we also know that there may be families who face lots of barriers to social determinants of health, that bringing them in and having more of a concentrated in-person experience would be really beneficial for them, and frankly, more logistically possible for them rather than traveling back and forth or getting support over a period of time. So lots of different ways that we're thinking about using the suites. The suites themselves are a really cool design, and I have a picture. It's fairly innovative. We've talked to a lot of people around the world, and I'm really excited about the design. So we'll have a patient side and a caregiver side of the suite. The patient side is a little more traditional in terms of having wall oxygen suction, ceiling track lift, medication fridge, etc. But the caregiver side is designed like a hotel room. There will be space for up to 5 people to sleep in the room comfortably with proper beds and nice linens. And so it will be a big departure from the experience of sleeping beside your child's bed in an acute care hospital, which many of these families spend a lot of time doing. And also the ability to include family members and additional people that need training, education, and support. So the space, that's the design of the suite. It has an ensuite washroom shared between the two sides of the suite. And then there's lots of shared spaces in this area of the building. So there's a dining room, there's a family kitchen, a tube feed prep room, 2 big tub rooms, a youth lounge, a play space, some quiet rooms. So a whole host of spaces where families can be. Just checking my time. I think we're good. So this is really to say that this is a new program. So we really want to make sure that we're evaluating it properly so that we can show its worth, but also collect data that matters to families. So one of the ways that we're going about this in a somewhat innovative way is we're using the International Classification of Functioning Disability and Health, and we're creating an ICF tool so that we can make sure that we're not only collecting the traditional data that our health system traditionally collects, which is really around ICD-10 coding and disease and diagnosis and access to care metrics like emergency department visits and length of stay, etc. So rather than focusing only on those, we want to embed family satisfaction, so PROMs and PREMs for sure. But beyond that, we want to really be collecting data based on the ICF that is looking at function and participation. And so we're in the process of building this tool. There will be more to come, and I'd be happy to share about that at a later date. But it's a really interesting project that we're hoping can really shift the way that data is collected, not just at this new center, but in BC in general. We will also have some research spaces within the building that are sort of embedded right next to clinical care, so some opportunities for some patient and family-centered research. So I'll quickly go through the building design, and then we'll have some time for questions. I don't want to spend too much on this because I appreciate that not everyone is in Vancouver. Just to say that this is really the building design concepts that we that we sort of stay true to throughout the planning process. So this welcoming, calm, non-institutional environment, honoring the land and this connection to Indigenous First Nations and local residents, connection to nature, accessibility being huge, but not just physical accessibility, also sensory accessibility, and really recognizing the broad range of needs and individuality within this population. And then, of course, this need for us to be virtually connected in a way that enables a good experience. You've seen this one before, so I'll skip over this. This is just the front entrance. There's just a few things I'll highlight. So this is a ramp in the atrium that's sort of like an iconic part of the building that will have really beautiful art, and families. The original architect is it was a bit sad and funny that, you know, the original architect had this like really beautiful staircase that went up the center of the building, and the families were like, "What are you doing?" And provided some very clear feedback. So that was one of the big first changes that families made in the design of our building. This is an entrance directly into child and family suites. So you can see the facade of the building looks, you know, a little more home-like and more neighborhoody. The area of Vancouver that this new center is in is very much a neighborhood. So it's a lot of like houses and low-rise buildings. So this kind of fits with the site. And because the site is on a slant, it enables us to have higher levels at other areas, at other aspects. And so you'll see this is from much lower down on the site, looking back up at the building. This is the wood area, is the all nation space. This is the big ramp. That's another visual of the all nation space. It's 2 stories. On the bottom level, we have like the cafeteria, a teaching kitchen, which will be used for teaching and training, kind of like a food show opportunity, or a cooking show, I should say. The second floor is like the welcome area, family resource library, sibling center, some quiet spaces, and some of the resources. This is the area where child and family suites are, except it's like at the back of the building. And then also the outpatient area. And then on the top floor, it's a staff only space, which will be called our care coordination hub. And this is one of the courtyards within child and family suites. So just families who are admitted to child and family suites will have access to 2 of these types of courtyards. And this is just the site in general. And what I like to highlight about this one is that we have this wellness path that circles through the entire site. And this really big grove of trees down below the building that you saw in one of the pictures, the former use of this site, the building has since been demolished, but the former use was for the previous rehab hospital before they moved over to our acute care campus. And sadly, this beautiful area was never accessible to children in the population who need mobility devices, because there was like a steep slant down into this grove of trees. And so that was one of the big things that families told us, is like, we need access to that area of the site. And so this wellness path will have various different accessibility, sensory, Indigenous, and art sort of focus areas throughout the path. And that is it. So I will just stop sharing and happy to answer any questions.
Thank you so much, Tessa. That was a remarkable insight into all of the work that you're doing over with the centre. It's, you know, I feel like a world first in that it's really looks like you've centered a lot of the work on the family's needs, which is, you know, what a lot of our families say. I'd like to open the floor to any questions or thoughts. Kayla.
Thanks, Tessa. That was such an amazing presentation. It's so wonderful hearing how far you guys have progressed in all of your planning, and how everything's coming together. So congratulations, and how exciting that the building's going to start early next year. I imagine that there's a lot of excitement and maybe some nerves in seeing things actually come to life.
Yeah.
Can you tell us a little bit more about the longitudinal care coordination, how long you expect families to stay on the service for, if each kind of care coordination triad will hold a caseload of about 150 families, how many triads are you expecting to have to kind of that number of 2,000 to 2,500, will you look to eventually have capacity to potentially have all of those children within the service at once, or what will that look like?
Yeah, good question. So I'll answer a couple different pieces. So in terms of the whole number, we don't expect that upon opening, we will have 2,500 children in the population. So we're thinking about different strategies to bring families into the care coordination model. And hopefully some of that will be through early implementation starting next year or the year after. We're exploring different ways of doing that. We have some existing services at BC Children's that we can start to sort of test some of these ideas with. So we really want to be able to do that. So hopefully by 2028, we'll already be providing this care to some portion of the families. And then we've thought about different strategies. So we know that there's a few subspecialty clinics at BC Children's who have a high number of these kids in their population. But we also want to think about families who are maybe outside of the BC Children's Hospital sphere. So thinking about going to specific communities and linking with generally through the pediatrician or healthcare center to ask them, like, who on your caseload meets this criteria, and let's connect them first. We will eventually, when fully operational, have a range of referral options, including self-referral. But as we slowly ramp up, there's sort of strategies around how we'll do that on an ongoing basis. And part of that will also have to do with the amount of staffing that we get. We're waiting for Ministry of Health approval on the staffing list and all of that. So still, to be determined. We're sort of working in this like realm of uncertainty right now. So I try not to think too much about it. In terms of the caseload, so I mentioned that navigator triad. So 3 full-time staff holding a caseload of about 150. We'll have 16 of those triads. So 16 logistics, 16 social work navigators, and 16 nurse navigators. And then those triads, 3 of those together will make up like a care coordination team that will be supported by a medical staff, a dietitian, and a pharmacist. And then we'll have that interprofessional team, which will include like teachers, behavior analysts, all of that, with lower FTEs that'll be shared by the whole population with really a focus around training and education. And so that it's those teams, so like 3 navigator triads, so about 450 families, followed by that sort of team. And there will be, we've thought about a lot of different structures and processes to enable sharing of information and cross coverage between that group. So that triad will really be like the tightest of the circles and really familiar with the 150 children and families on their caseload. But obviously the ability to provide some information sharing and leaning on each other from a broader team perspective. So we, between various different types of rounds, we're thinking about echo sessions with community-based teams. So for example, let's say a navigator triad that is connected with families on Vancouver Island, which is a region of BC, there would probably be a couple of triads followed because there's a lot of kids on the island. So maybe having an echo session on a monthly basis with the community on the island, so different strategies around how that sharing can happen. But this is what we want to test. So this is like, I've worked in various different care coordination models. I think we all, there's a lot of literature. There's a lot of ways that this can be done. There's no gold standard. But really there's some core elements that we know are critical, and the relational approach is critical. The regional approach, being familiar and knowledgeable with the people in community and the services and supports in community is critical, and partnership with families is critical. So like, we know that those elements have to be there. And I should also point out like the absolute need, and we've heard this from your team in Perth, like the absolute need to have it be part of their job description that they're working across sectors. So this is not an issue where the navigator says, oh, that's not in my job description, because that falls outside of healthcare. It is absolutely needs to be part of their job description to be intersecting with the school and the community-based resources. So a focus on that cross-sector attention is really important. hopefully that kind of answers.
Yeah, thank you. Do you have any rough estimate of how long you would expect a family to stay in the service? Is the idea kind of across while they're under pediatric care in general?
Yeah. Or? Yeah. So thanks for bringing that back up. I forgot about that part. So from the time they're referred, so it may be that they're referred in the NICU. So they're referred from infancy, and we follow them through until they graduate from the pediatric sector. So right now in BC, what that means is 19. But that's a huge problem, as we all know. So I don't want to make any promises, but our hope is that there's an opportunity to extend a portion of the care coordination service that focuses on transition up until an older age cutoff. And we've done a good environmental scan looking at all of the when pediatric services in BC and Yukon come to an end, and they're all at different ages. It's all very confusing. And so families talk about falling off the cliff multiple times as they go through these various transitions of different services and supports. And so really having the opportunity to provide a bit of a safety net through all of those other transitions would be really valuable. So that's a work in progress. No decision made yet, but that would be our hope.
Thank you.
Yeah.
Great questions, Kayla. Great answers, Tessa. Great. Anyone else in our group have any questions before we wrap up? Fabulous. Well, for those who are watching on YouTube, there will be the opportunity to ask questions on the Mighty Networks. Kayla, would you mind popping the presentation back up for me, please? So for those of you who are watching on YouTube and you haven't joined the Global Nursing Network for Rare Disease, what are you doing? First of all, please come and join. You can sign up via the QR code, so please scan the QR code on your screens, or you can come the old-fashioned way and go via our website, so it's GNNRD.org, and you can submit your account request there. And like I've said before, thank you so much, Tessa, for your time and your expertise in your presentation and giving us an insight onto the work that you're doing for families with complex needs and rare diseases. And it's something that we can all dream of happening in our own countries as the next step to care for our complex patients. So I'd like to take this opportunity to thank you all for joining live, and for those watching on YouTube. We will see you at the next one. Thank you so much, and we'll see you soon.